grand round speaker this morning, Dr. Ian Brown, well known to all of us here. One of our significant trauma surgeons, who I think all of you know has a large basic science interest and work that capitalizes on his PhD from the University of Chicago in immunology. But he's here today to talk about one of his other passions and great efforts of work that he's been doing here regarding the social determinants of trauma, disease, and specifically about the Wraparound program, for which you're continuing to obtain more funding to help with this work. So, Dr. Brown.
Good morning, everyone. How are you doing? I just want to build off of Dr. Farmer's theme of times are tough and we all need to support each other. That's kind of sort of the heart and soul of what we're doing here. And so I'll be presenting Wraparound 2.0, hospital-based violence intervention and comprehensive care of the violently injured patient. So I do have one actual disclosure. That is that my 8-year-old came in and picked out this tie, so I went with that. He also gave me some unsolicited advice. He said that the key was to not stare at people and look angry, but to smile. So I just want to start off talking about the cost of violence-related trauma. I think that that's the important way to sort of nest this and start the conversation. And I hope it's a conversation, and I hope that it gets people talking and thinking and wanting to take it to the next level. When we talk about costs, we define costs in a lot of different ways, and I just want to start with death in this case. So violence-related trauma is the 6th leading cause of death for all age groups, and the 3rd leading cause of death for 15 to 34-year-olds. It's unfortunately, very sadly, the 4th leading cause of death for children aged 10 to 14. And then, in addition to death, there's a much greater view in terms of injury and what that injury results in, the impacts on families, the impact on economy, the impact on sort of the social network and fabric that in which we live. There's nearly 1.5 million non-fatal injuries for young teen adults 15 to 34 years of age, and an estimated annual direct and indirect cost of approximately $12 billion in terms of lost wages and damage in terms of economy and property and things like that. At the end of the day, you can't put a price tag on this. These are lives that we're talking about. And then it is important to bring up that violence-related trauma disproportionately affects minority populations. There are many reasons for this, and this comes into the social determinants of trauma, which is a whole talk in and of itself, or maybe a series, but I'll just get down to the numbers. Homicide is, of course, the leading cause of death in 15 to 24-year-old African Americans. It's the 2nd leading cause of death for young Hispanics. And recidivism rates are between 20 and 55%. What that means is, basically, if you get violently injured, that means that there were a series of factors in your life that increase your risk for having a violent injury, right? Well, it turns out if you sort of self-identified as having that high risk, then you are in a population that is at high risk, and you sort of self-identified yourself as being at a greater risk for an additional injury. And so that's what we're talking about there. To shift a little bit specifically to firearm deaths, there are 33,000 annual firearms deaths. 35% of those are homicide. The vast majority of firearm deaths are actually suicide. And homicide, while it does have some disparity in terms of who it affects, suicide is much less so. It seems to be a lot more evenly spread, or actually shifted more towards Caucasian Americans. Homicide, however, is the 3rd leading cause of death, as I said, among young Americans, and the burden of homicide is such that it primarily affects African Americans and Latinos. Just to bring it home a little bit, we want to talk about the UC Davis Medical Center stats. Here in Sacramento County, violence is the number 2 killer of young people. So we have a number of homicides every year, at least 20 or so, and thousands of people are violently injured. We treat over 800 patients a year for violent injuries here that come through our trauma service. And a third of those are teens and young adults, sort of the core nucleus of who we are as a community and who we will be in the coming future. The emergency department and sort of the trauma center are sort of a window for many people to the healthcare system. So it's sort of a funnel that provides an opportunity to engage the most at-risk local population. So how can this be done effectively? That's the question. So it starts with changing basically how we look at violence. Violence is complex. It has many factors that contribute to it on many different levels, at the level of the individual, the family, and the community. Similarly, most of the problems that we deal with in medicine are also similarly complex. We don't just manage a heart attack by treating the heart attack with a cath at the door and stopping there and sending the patient back home to the same situation that progressed them to the heart attack. We take a public health approach, right? So if a person is at risk, maybe we identify them ahead of time and we get them on an exercise regimen, affect their diet, get them on medications that are preventative. Maybe we don't catch it until the actual heart attack happens. We acutely manage the heart attack, but then we send them out on an exercise regimen, a diet, cut out the fat and cholesterol, and we put them on statins and other drugs. So there's sort of it's not a snapshot, it's a long-term vision that starts sometimes even before the event. Turns out that you can do that with violence too. It's just that we never in the past really took a look at doing that in that way. And it's only been basically in the last 10 or 20 years that we've changed our idea about that and changed the model. Violence as a public health issue. This has been a much more popular topic recently. There's a Dr. Slutkin out of Chicago initially who then went to the CDC, who basically was one of the first originators of this concept with his Cure Violence program. But basically, a public health approach to violence would focus on mitigating modifiable root causes. These are there's risk factors and protective factors in any community. And you start by identifying the factors that shift you in one direction or the other, the risk factors or the protective factors at each level, the individual, the community, the family unit, the whole society, and the perceptions. And so you have to think about each act of violence basically is built off of and affects families and communities and populations. This is essentially sort of a even more in-depth breakdown of kind of how that looks. So on the individual level, you're looking at demographics, what the attitudes are towards violence and how normal that is considered for that individual in terms of how they perceive it and how they think it is perceived. Conflict resolution. Conflict resolution is interesting because I think that it tends to be context driven, right? So like, you know, I used to be a bouncer, and the way that we handle conflict resolution in that particular setting is different than the way that we try to get somebody to come see a consult. So.
Could you offer some additional training, perhaps?
It's just, well, you know, social employment status, mental illness, a lot of things like that, and a lot of things are context driven. And I want to bring up the context driven thing too, in particular, because it affects the way we perceive patients as well. So it's very hard to understand somebody else's perspective and why they're doing things that you don't understand if you don't have empathy or the ability to put yourself in a different situation. And often it is a situation that you may or not ever be able to understand because, frankly, you've never walked in those shoes. And so in order to like really effectively intervene on behalf of somebody, you have to have a certain amount of humility and perspective and ability to consider that what may work in your world does not always work in every world in the same way. And that's at the individual level. Interpersonal, family violence, dysfunction, support or perceived support, perceptions of lack of support. Abuse, sort of the environment in which you grow and the way that your circle sort of handles itself. Reinforcement versus discouragement. Is the social circle building a person up or holding them back? Cultural norms. Then it even gets bigger, and then you start to transition from the individual level to the systemic level. Protective institutions. We have a lot of discussions nowadays about community relationships with police, for example. It's not always the same. Access to educational or employment opportunities, prevention efforts. And these can be quite complex. Some of you are familiar with the University of Chicago study where they basically gave out the same resume and they changed the names a little bit and decided who got hired and who didn't. And if you were Jamal, you didn't get hired, but if you were Fred, you might have got the job. Is you aware of that study? So what it ends up being is there are multiple contributions that make a society sort of different and unique, and some of those factors can modify or increase risk towards violence, and some of those can be protective. But it's important to break those down if you're going to have an effective public health look at what contributes to violence-related trauma. So, the first aspect of public health intervention is prevention. And so how do we successfully create prevention interventions? I have this little picture here, which actually I stole from a show that my wife used to watch, which is a Filipino teleserie, and they used to say kapit bisig, which is basically means like arm in arm together. And so that's what that's about. And that's what it takes, coming together. So, person-centered. We have interventions have to be basically client sort of driven, or not driven, but sort of targeted. So they're client specific. So their life matters. We recognize and respond to trauma. And when we say trauma, that has a big definition. So it's not just the assault that happened or the gunshot wound. We're talking about sort of the whole picture, intergenerational stuff, structural stuff, historical, personal. How did they get to be that person where they are today? It's actually kind of complex and it's layered. It's not just basically like somebody woke up and they got sort of beat up by the kid around the block and they turned bad. They started off in a situation that was built based on a historical legacy that's probably a couple hundred years old that put them there, right? There's a reason that we live in the neighborhoods that we live in, right? Redlining, racial covenants. They still have racial covenants. I don't want to get too off tangent, but I do want to mention that. In Sacramento today, you can find racial covenants on housing contracts in 2020. So there's a reason. And so what I'm saying is you have to recognize and respond to the trauma, the whole picture, and not just the individual thing. You have to employ the use of a credible messenger. What does that mean? Anybody idea? I'm going to get you guys involved. What's a credible messenger? Kyle, you know I'm about to call you out, right? No. So a credible messenger, it basically means that, like, if I'm talking to my patient and my patient gets the sense that I have no idea of where they're coming from, then I'm not going to be able to offer a whole lot of advice of how to help them in a situation that I can't relate to, right? It makes a lot more sense if I actually know the shoes that they're walking in. So that's what is meant by a credible messenger, somebody with a lived experience who can speak from a place of authority because they know kind of all the sides of a problem. That's what that means. Authenticity is key. It has to feel real, otherwise people won't buy into it, because we're talking about stuff on a very deep level, and you have to allow yourself to be vulnerable both as the provider and as the person who is getting help, and that may not always be the natural reaction. You have to expose new ideas, ways of thinking, life skill, and offer building. But this is not a paternalistic approach. This is an empowerment approach. And there's a very important key distinction between that. I don't want to be the person high on the hill telling you how to live your life. I want you to say, this is what I want from my life. And then I'm going to tell you, this is how I think that we can help get you there. So empowerment versus paternalism is something that's not always said out loud, but it is a very, very important key issue in how you manage something like this. You have to engage the community development, empowerment, and accountability, encourage and foster continual personal growth. You have to raise awareness and support linkages to service. So oftentimes it turns out that in many communities there are a lot of people who care a lot and they have resources, but people may or may not be aware that those resources exist or how to get to them. So they need a conduit, somebody who shows them the way. You got to bring people to the water. Many people are already ready to take a drink. And then you have to be positive and reinforce, just like in the morning in trauma when we do our gratitude, right? That's important. You got to celebrate and support advocates and service providers because this work it can drain you emotionally, and you got to build up just as much as you. It's a giving job, basically, right? And you have to have something to fill you back up. Otherwise, you're going to be very empty. I'm actually smiling under this mask. I know y'all can't see it, but I just want to bring that up so that my son is aware of that. So there are many particular examples of community-driven initiatives with proven violence reduction, and they're all throughout the country and and throughout the world, actually, in places that you might imagine. And then I just wanted to highlight one approach, the hospital-based violence intervention program. They are picking up steam, and as of the time that I made this slide, there were over 35, but I imagine by now there's a lot more because we're starting to know what we're doing, and we're starting to figure out how to effectively roll them out. So I'm basically going to talk about the programs using our program here as a model. This is our team. Some of you may notice that there's a group of them sitting over there in the corner. That's intentional so that we can all engage, because I think one of the things we were talking about with consult services, for example, is it's a lot easier that if you know everybody and everybody's able to talk to each other. So this is our Wraparound program. We call this 2.0 because previously we learned a lot about what it takes to sustain a program and keep it durable through an effort that we had initially in 2009, which we learned some tough lessons about how to keep it functional, I think, and those have been really informative both for us as a program and for others who have tried to replicate the same sort of success. So we have, I'll introduce them a little bit later, but see, maybe I can do this. Can you guys see the arrow there? Okay, this is Nicole. That's actually me right there. This is Shani, Christy, Chevis, and Esmeralda. Okay. So, back to what it is that we do. The Trauma Center's role in public health and prevention. So as we said earlier, recidivism is a big problem. So 20 to 40% recidivism rate after being a victim of assault. 20% of homicide victims are treated for a violent injury in the 5 years preceding their death. Anybody here who's been around for 5 to 7 years and is now a chief resident probably has taken care of the same patient twice at some point, right? It's just a thing. You'll start to see somebody, or you'll see just the patient that comes in and you're getting ready to work them up for trauma, and you got this like x-ray and there's a bullet that doesn't match any of the current holes, and you're like, what is that about? And it's because it's been there for a while, right? You guys have seen that. I know some of you have seen that with me when I'm on service, right? So then we start with risk reduction strategies, because we're centered right there at the moment of opportunity. So we utilize a moment of opportunity. What is a moment of opportunity? We used to call this a teachable moment, but I never liked that term, because I don't think that I can teach somebody something when I don't completely know what they know about their story. I think that term is a little bit sort of pretentious and paternalistic. I think it's a moment of opportunity. You have somebody that comes in with a brush with death or injury seriously, and oftentimes people in that moment are reflective, and they say, how did I get here? I don't like this place that I'm in right now. I want to be in a different place. And so they tend to be open to changes that will empower them to move in a different trajectory. And so in that moment, they're looking for the signs and directions that will help them get to where they now want to be. And they see it. There's a path. And so that is the moment of opportunity. And it's brief. Sometimes it can be, because sometimes you get back to what you're used to and things can sort of fall into place. It's just like anything that we've ever tried to do that's difficult, right? And your habits can become sort of the default, and it becomes easy to fall back. So you want to utilize that moment of opportunity. Then you want to come with culturally competent case management at the bedside. What do we mean by culturally competent? It's the same thing with the credible messengers, right? Everybody's story is a little bit different, and you may or may not know completely everything about the story. So sometimes it's a little bit easier. So this is an intervention that requires a lot of trust and vulnerability. And it can be very difficult if there are misunderstandings or assumptions in the beginning. And so it's a lot easier to have somebody that sort of knows what the deal is because they've lived it. And so that's what we're talking about, culturally competent case management. And then ultimately, community partnerships. Hospital systems in and of themselves are not specifically designed at this point to deal sort of longitudinally with a lot of the issues that are going to be relevant for violence-related trauma prevention. But the communities tend to have a much better grasp of what's needed because they're the ones asking for it. So oftentimes they will have the resources already together, and it is in partnership with people that have certain expertise that makes this a lot more efficient and doable, right? So then we take the public health approach, and then that includes injury surveillance, research, prevention, evaluation, policy, services, and advocacy. So on the individual level, it starts with the moment of opportunity, culturally competent case management. And then on the grander community level, we're tracking all that comes in. We're trying to see why. We're doing the research to figure out what works and what doesn't work. How can we most effectively do our interventions? And we're doing evaluation. You want to have an honest picture of what is working and what's not. And that's important just not only so that you can go forward, but also because you need to engage your stakeholders and you need to show them that what you're doing is actually effective and meaningful. Once you see kind of what's going on, then that information can inform policy. And then you can change things like within the hospital system, what is standard of care practice? At the state level, what's actually effective prevention? And based on that, you can generate services and advocacy. We support holistic recovery from violent injury. We transition patients from the hospital to long-term community and natural support. Trauma used to be a treat 'em and street 'em kind of profession. Basically, you patch the holes and you put people up. It's no longer that. That's not good enough. I think now we're learning that there is a need to transition patients from the point of discharge to something going forward so that they don't have to come back to the hospital on terms that are not their own. Relationship-based care through a continuum of recovery and addressing social determinants of violence. I think this idea of addressing social determinants of violence for me was one of the most difficult things to get my head around. Not conceptually because it's not important, because I know that. It's just the idea that how do you address a public health problem at the level of the individual and think that that's going to work. But I think that it does, because I think that every time you make a successful intervention, it's like you're planting a seed or a domino, basically. Because perhaps you change sort of the intergenerational transmission of some of the same social determinants. Basically, you put people on a different trajectory, that affects their whole circle, their family, everybody that they teach or that they influence. And so maybe it is that you can have an influence and that works. And that's sort of, I can be a little tangential, but just, I'm going to take 2 seconds. That's sort of the advanced peace idea of going into a city and addressing the most frequent violent offenders and basically stopping all the violence in the city by stopping that core group. Right. The program is based on what we call violence prevention professionals, or case managers. They have to be credible messengers. They have to come from the community, understand urban violence, and have knowledge of the community. The community has to recognize them as being of their own, otherwise it doesn't work. They empower clients through mental health care and risk reduction resources, and these resources do a lot of different things. They help with employment, help with legal issues, tattoo removal, educational opportunities, vocational training. It's a number of things. Basically, they identify a series of goals, and they help people find ways to achieve them. There's an accountability of the clients, because ultimately it's the client that has to do it for themselves, but they do get shown the way and offered encouragement. Depending on the program, the interventions are different lengths. Our program uses a 1-year intervention. I'll just skip this slide, even though it's cool. The UC Davis Wraparound program, basically, we target individuals between the ages of 12 and 26 years that are injured by interpersonal violence. Basically, what this means is patients that have experienced gunshot wounds, stab wounds, or assault. These patients are admitted to the hospital and the trauma service, and that's part of how they are identified. We do exclude suicide, intimate partner violence, and child abuse. We exclude prisoners and level 1 mental illness, schizophrenia, bipolar disorder. We're just not equipped to handle that. I have this up just to show our violence prevention professionals, Chevis and Ez. And I just want to emphasize that they work as conduits to connect resources and as agents of change. When I say agents of change, I don't just mean for the client. I think that's the old model. That's the old way of thinking. The violence prevention professionals actually are agents of change for the entire hospital system, because it turns out that whether or not you think about it on a conscious level, there are things that we do that affect the patient experience. I'll bring some of those up later, but I think that by bringing awareness to what the program does, it sort of changes the way that treatment occurs and that patients are engaged in the hospital in a positive way that helps patients sort of be supported in continuing their own trajectory and being empowered. So this is kind of our sort of flow pattern. Basically, the patient gets admitted to the hospital. Our team will scan through the electronic medical records for hospital admission that meet the criteria for intervention. Additionally, sometimes patients are directly referred either by the trauma team itself or by actually sort of nurses on the floor who are aware of the program and see an opportunity. Then there is a referral. The intervention specialist or professional reviews the chart and will visit the patient at the bedside. One of the issues, which I'll bring up a little bit later, is that just sort of one of the natures of challenge for the program is having enough availability. So when do most of our violence-related traumas come in? Overnight, right? Between 10 and 2, like the steering wheel, right? 10 and 2, right? We don't actually have coverage at overnight, and so that can be a challenge, just because I think, when you're trying to get the funding and have availability, there's not a whole lot. We can't provide 24-hour coverage at this point, and so that's one of our long-term goals, is to be able to have people that are available. And so basically our idea is to have a sort of intervention, or at least let patients know about the program should they come in on a weekend or overnight, and then sort of set up possibly for a conversation on a weekday morning. They are enrolled and consented during the meeting, and then an intake is completed, which is basically an interview and a series of surveys and things, just to make sure, sort of to see where people are, where they want to be. And that's sort of how the relationship is built. That's the very fundamental thing. And so sort of there's this feeling out period, like, this is who I am, this is who you are, this is what I can offer, do you want it, do you not want it, kind of that sort of thing. It's a relationship builder. It's not speed dating, but it's a little bit more complicated than that, but it kind of is, right? And then the real work starts after discharge, actually. I mean, the relationship building is the real work too, but we don't stop once the patient leaves the door. That's when we're getting revved up, right? So discharge, address critical needs, identify goals, connect to resources, meet regularly, hold each other accountable, see what the progress is. And then gradually transition to national supports, and then we say all the best, and we know that you're going to be doing well. And that's what happens, or basically over the course of a year. So how does one build a program like this? It can be very challenging. I think initially it's a bit of a struggle when it's a new concept, because you have to convince a lot of people that this is a worthwhile endeavor. And that can be difficult when you know that it's going to be, resource intensive and require a lot of commitment. So this is what you got to do. Number one, secure hospital buy-in. That's basically 3 words, but it's much bigger than that. So you secure hospital buy-in, you select your target population, and that has to be a realistic thing so that you're not overstretched and so that you can most effectively and efficiently use whatever resources that you have. Establish your program goals and objectives that have to be in line with your hospital buy-in part and your stakeholder commitment. Streamline a referral process so that you can identify clients and get them to you in a way that works and is effective. And then engage with your resource networks. That means you have to get out and you have to know people in the community. If you don't know anybody in the community, this does not work, because you need to connect people with resources, and the resources need to know what your street cred is, quite frankly, because they're not going to reach out for you if they don't know who you are and what you represent, or if they're suspicious of that. So you have to be very authentic. You have to make informed direct service staff hiring decisions. Particularly in the beginning of the program, you need 100% commitment, and people have to be kind of in line with that. And it has to be one vision, I think, just because you're trying to move a mountain, and it doesn't work unless everybody's pushing the rocks in the same direction. Effective evaluation. We actually built our program on effective evaluation. That's important because that's the only way to get stakeholders engaged and committed. You have to show them, as I said, that you're going to meet success. And you have to set funding goals for sustainability. You have to have a plan in place for figuring out how to make the project sustainable, because otherwise, it's just stress that you don't need, frankly. But you have to have a vision that incorporates that. In an effort to sort of make these programs a lot more sort of uniformly available, the national organization referred to as the Health Alliance for Violence Intervention, or the HVIP, has over the years put together sort of a packet of information of how to do this effectively so that people can roll these kind of programs out, and who they need to engage, what conversations need to be had at your hospital, for example, so that this can be done effectively, so that programs aren't reinventing the wheel, because you're already going to be strapped in the beginning, and so you need to basically make the most use and the most effective use out of what you have when you do those first engagements with the people that you need to talk to get the program off the ground. That can be found at this website in case any of you guys are going to any of the hospital systems and you see the need. Just be aware that such a resource exists. This is sort of a lot of the same sort of things. I think I wanted to focus on a couple more key points on this. Developing community partnerships is key, but I think another key is hospital champions. Hospital champions, basically, you need somebody basically from your nursing department, somebody from your trauma department, somebody from your department, well, not your trauma department, your trauma division and your surgery department. You need liaisons through all those organizations basically to make sure this thing work, because you're going to need a lot of help and you're going to need a lot of people believing in the project. It doesn't work without champions, and champions can facilitate sort of what your deficits or weaknesses are. For example, by having nurses that helped early on with referral, for example, we were able to sort of extend the work of our violence prevention professionals. And so that part is key. And then finally, accountability and evaluation. You need people who know what they're doing with the evaluation part, and if you don't have that yourself, you got to build the right team around that so that you can produce scholarly work and show people that sit at the big table that you're doing something that should give you a seat there as well. A few more words about the violence prevention professionals as change agents. As I said earlier, I just want to sort of reemphasize that agents of change for the patient, for the community, and for the hospital. For the patient, support, advocacy, and guidance. This is sort of fairly obvious. But for the community, I think that your work has to be, sort of give credence to your program. And so we're sort of ambassadors for the hospital to the community that we serve. And the hospital has to perceive itself as being part of that community, not just within that community. But I think that the violence prevention professionals are a direct extension saying that, this program is here to help, and we're going to engage the community, and we're going to be right out there with it, which is sort of like helps change perceptions of the way that we're perceived in the community, and it changes social norms. It also changes social norms within the hospital system itself. There's staff education, destigmatization, legitimacy to the work, and we model behavior so that we sort of like help spread sort of this idea of trauma-informed care. So you have to identify and overcome barriers so that you can have successful outcomes. And there are barriers at each level. There's social determinants within the community. There are personal barriers that people may have, for example, with sort of conflict resolution or, other kind of barriers that are existing that are contributing to their own social determinants. Barriers within the hospital experience in terms of communication, advocacy, implicit bias, and discharge barriers. I'll give an example of that very shortly, but I don't want to set that up. And then there's discharge barriers, such as access to care issues. When we send our patients out, not every patient has the same resources. Some of them can't come back to the clinic in the same way because of needs that they have that are specific to their job or their family issues or transportation issues, for example. There's plenty of barriers to access to care, and it's important for us to understand that when we do discharge planning so that we have an actual functional plan. That's the whole breaking down barriers there. I included that. He was a doctor too, so that's why I included it. And then success. What is success and how is it measured? So what would your idea of success be if you were looking at a program like this and you want to say whether or not it works? Anybody have any ideas? You can even cheat off of the board. Anybody? Yes. So a decreased recidivism rate, right? That's a straight number that you can look at, right? And you can say, okay, well, for this period, for this 10 years, it was like 20%, and now it's like 15%. So maybe there's an impact. That can be difficult to measure sometimes just because it takes a little while for you to get that number back, and it's not something that you're going to get back quickly. But it is a measure of success. Anybody else? Anybody else? No. Okay, we can't be spectators in life. See, we got to be in it. You got to be engaged. Cost, right. So cost is a very important thing. So it turns out that basically, if you can prevent 3 patients from coming back to the hospital with a second violence-related trauma, that actually will pay for the cost of the entire program that you have. This is a number that's been figured out by other models. For example, the UCSF Wraparound program, from which this was initially spun off of, that was some of the work that Katrine Juilliard and Rochelle Dicker did. So cost. Well, it turns out that the idea of what success is different for each stakeholder. So when you go to the AAST meeting for trauma and they're talking about this, their idea of success is one thing. And when you go to a group of social service providers, their idea of success is very different. So what does this mean? This means that when these conversations are being had, it's very important as to who's having the conversations when it comes to forming policy, because the policy is going to be based on the loudest voice and what their idea of success is. So it's important actually to have contributions by all of the voices so that you have a real comprehensive idea of what success is. And that way, you know, the literature will reflect that. So yeah, cost savings, policy change. Some people might say, well, we want to have a decrease. If we basically were to survey implicit bias among our staff, we want to see that it's different from when we started, when we finished. We want to decrease, we want to basically see that all our patients have met whatever their goals are that they said that they wanted in 1 year. We want to see that our retention rate is over 85%. There's a lot of potential ideas of what success is, and so you have to build in the right kind of evaluation so that you can measure that. Well, it turns out that you need a lot of people with a lot of different expertise in order to measure that, because, you know, I do selectins and leukocyte. It's like I'm a biologist, right? I don't do public health medicine per se, although I'm learning it. But what I'm saying is, in order to do that, you need to have experts. And so that's what we've brought in. We brought in people that know how to do qualitative evaluation through interviews. We brought in the health economists. We brought in, you know, a lot of people with a lot of specific expertise. You know, it's like I say, like, I guess, you know, I could take out a thyroid if I needed to, but I would rather call Mike Campbell because I know that he's going to be able to do it right because he does it every day, right? I could take it out. So in just looking at our successes and our areas for improvement, I just wanted to touch on sort of what we've been doing over the past couple of years. We keep track of basically how many violence-related injuries we have and sort of how we are able to engage those patients. This is just a breakdown in terms of age and race and type of injury for all of our violence-related injuries over the past 2 years. It's a decent number. As you can see, the males tend to be a little bit more represented, and predominantly the majority of the patients tend to be black. What I will also like to point out is that somehow between 2019 and 2020, we've had a little bit more trouble figuring out the race part. And we have to sort of identify why that is. And it's actually, I think, important to be a little bit more sort of insistent on getting that information if we're going to be able to use it in any kind of way. And I think that what has been happening is that people are just checking the unknown box when they come in. Maybe because it's a question that people feel uncomfortable with, or they just don't have a good way for patients to self-identify at this point. So then we need to know, like, of the patients that come in that are actually violently injured and eligible for wraparound, how good of a job are we doing at getting those patients? What things can we do to change that? Is there an opportunity to improve, basically, our successful enrollment rate? And then sort of what are the opportunities that are missed, and how can we address those? And so when we look at the number of patients that were eligible for violent injury, that's, was it 50, 60, 70 basically patients that were enrolled And then we looked at basically who's enrolling and who's not. What we have seen traditionally, previously, is that women tend to be on board a little bit more than the guys, and we have to figure out why that is. I'm sure we could speculate as to reasons why. But that's one of the efforts. So if there's a stigma to getting kind of help like that, then we have to develop a plan on figuring out how to overcome that stigma, and that is an opportunity. So you can think of it as something that's not happening, or you can think of it as an opportunity. And I think that there is an opportunity. Why don't people want help? How can we change that perception if that's what it is, if it's a stigma, and then maybe we do a little bit better going forward. I think a big difference between 2019 and 2020 is that the overall sort of conditions have changed a little bit on several fronts. There's this virus thing going on, and then the political climate is also a little bit more charged. We don't know specifically why our enrollment rate has decreased, but we suspect that there are some contributing factors that are along those lines. Things are just a little bit tougher now this year in particular, I would say. That being said, I think Dr. Schass had pointed out some data that he had put together himself showing that violence-related trauma incidents were actually up very significantly. I think he said like 70%. He may be on the line. He might be able to chime in with a number, but it was pretty high. So things are a little bit different this year. Our refusal rate was 36%, or basically between 36% in one group and 18% in the other. We were getting all the women. And then we had this other opportunity, which is called missed. So missed because they either came in on the weekend or because they came in with an injury that didn't require admission was often the issue. So say somebody gets shot in the leg, it doesn't hit a major vessel, they get it washed out and then they go home. Those patients oftentimes aren't here long enough to get engaged by our program. What we also don't know with relation to that is, does the severity of your injury correlate with your desire to want that moment of opportunity? We've never really directly measured that, but oftentimes when people really have a real brush, I think that's when people tend to be a little bit more receptive. Another point of emphasis, which I don't have a number for on this, but I will tell you, initially when we had a lot of those missed opportunities, we tried to call the patients back on the phone and try to engage them in that way. Of the over 30 or so phone calls that were made, I think we had one patient who was sort of, 60 patients that were called. I think there was one patient who thought that maybe an intervention might be a good idea. The phone calls don't work. You have to have a personal thing there, and you have to capture it in the moment, otherwise the moment is lost. I think that's the postal piece of information, and we're working on that part too, because I think that that sort of builds support to that whole idea of this moment of opportunity. The phone calls don't work, which is why one of our big goals, particularly with our funding, is to get the coverage that we need to sort of expand our coverage and have more than just, two people working around the clock. Once we engage our patients, we document in EPIC, actually. Why is this important? This is probably the first program in the country in which the violence prevention professionals have been given that kind of legitimacy where they're actually able to use EPIC. This is important because it will be a piece that will allow for further evaluation. Additionally, it will help with policy changes. There's been a lot of support, at least in this state and a few others, for providing funding for the work that violence prevention professionals do. But if you're going to provide funding for that kind of program, you need to have a way to document and track the work that is being done. A lot of the work previously has been done informally, but now we're going legit. And so we think that this is going to actually be a very important step going forward. It also allows other members of the healthcare team to see kind of what the work is that's being done. I read, for example, the social worker notes on a lot of my trauma patients so that I can sort of inform myself as to what the situation is that's going to affect discharge or safe discharge, or if I have to be thinking, for example, about elder abuse or child, just things like that. Because I know that that's what they do, and I know that they're going to focus on that. It's the same kind of idea here for violence prevention professionals. Next part of the evaluation is not just sort of tracking sort of what they're doing and the goals, but actually looking at sort of what the